get started. Okay, hi everybody. Berenice, who would normally be presenting, is the Glamorous Assistant today, but some of you will know me. I'm the regional learning coordinator for social prescribing in London. There are various counterparts of myself across the country supporting link workers in their day-to-day through peer supports and learning opportunities. I'm actually based at the Bromley by Bow Centre and also part funded by the Healthy London Partnerships, and so work closely with the Bromley by Bow team in a number of the different projects like the Insights and some of the social prescribing stuff. So pleasure to be with you all today. Really excited to hear from all of our wonderful speakers. We're almost a year on from the social prescribing rollout in primary care, and it feels like a really good time to talk about all of the various different people that need to be involved in delivering social prescribing, and how as social prescribers or as clinicians or even as commissioners, we make sure we're talking to the right people in our roles to not only develop something that is very much in its really in the grand scheme of things in its infancy, even though there are obviously some very established social prescribing programs, and this is something the charity sector has been doing for eons, taking an asset-based sort of holistic personal approach to the individuals that they're working alongside. In real terms, in primary care, this is actually quite a new invention. So we've got some really great speakers today. We really want to know who's here, so please do complete the polls that are popping up on the screen right now, just so that we've got a bit of an idea of who we're talking to and where you are, and what your sort of your focus is. So we're going to hear today from Dan Hopewel, who is one of I don't want to say dinosaurs of social prescribing, because he does exist. It is true. He is a real person. And he is just a wealth of knowledge about social prescribing, and has sort of lived through Bromley by Bow, going through all the teething problems of setting up their social prescribing early doors. And Najnin, who is currently our training and development, our social prescribing training and development manager. So she trains a lot of social prescribers around the country and is currently training a huge cohort of social prescribers in London. But actually prior to that, helped set up our social prescribing programme at the Bromley by Bow Centre, and was managing that programme for a couple of years. We're then going to hear from, obviously Bromley by Bow is a different kettle of fish, because we have a health centre on the same campus as our community centre, and we have very close relationships with our PCNs. It's been quite integrated from early on. We want to hear from some people that aren't in that situation. So we've got Khadija from the Hounslow, one of the Hounslow PCNs, with her clinical director, talking about some of the teething problems and actually some of the things that they've implemented to initiate social prescribing into the practices across their PCN, and some of the things, give some tips on some of the really practical things that have worked. We're then going to hear from Dan again about his role in London as the regional facilitator, and I'll be talking a little bit more about what being as a learning coordinator, what some of the opportunities that are being created to sort of bring bits of the system together, and then we'll have a bit of a Q&A with whatever time we've got left after the presentations. We're then going to put people into small breakout rooms, so you can chat amongst yourself about some of the stuff that you've heard. One of the problems with doing webinars is that you don't really get that after the meeting chance to debrief. So there'll be a bit of a chance to chat to some people about what you've heard. We'll come back, share some of the bits and pieces that have come out of some of your reflections, and then we'll wrap up and close. So really lovely to have you all, and I think we'll crack on. Let's hear from Dan. Do you want to introduce yourself? Danny, I think you might be on mute if you're trying to talk. Dan.
Right, sorry, I couldn't unmute. Great. Thank you very much, Leanna. That's a great introduction. So I'm Dan Hopewel. I'm the Director of Knowledge and Innovation at the Bromley by Bows Centre, where I've actually been for the last 21 years. And I'm also one of the regional facilitators for London, supporting the development of social prescribing across London. And we'll talk a little bit more about that later, but working very closely with colleagues from Healthy London Partnership and NHS England and the 5 STP areas in London as well. So I just wanted to talk a little bit about, and I think you raised a really interesting point there, Leanna, about social prescribing. It's new. In some senses, it's something that the voluntary sector would probably claim to have been doing for decades. And if you really want to take it back, you might argue that it's really reinventing the strong connections and good neighborliness that exists and existed particularly in strong communities for potentially hundreds of years. So it's a really interesting to sort of think about what social prescribing is, where it's come from, and where it's going. And the title of our this webinar today, Everyone Needs to Be Involved, I think really references that point, that this is everybody's, social prescribing is important to everybody and everybody needs to be involved. I'm going to talk just for a couple of minutes about Bromley by Bows' journey into social prescribing, because I think it gives us and potentially other voluntary sector organisations a particular perspective on social prescribing that is really critical now as social prescribing has been adopted really wholesale and fantastically by the NHS. Bromley by Bows' journey, for those who don't know Bromley by Bow, and if we weren't under lockdown conditions or semi-lockdown conditions, all of us would probably be sitting at Bromley by Bow today and in really presencing this incredible centre that we have created in East London. But Bromley by Bows' journey started 35 years ago in a dilapidated East London church with a small and old and dwindling congregation and a young priest who arrived to encounter a sort of set of semi-derelict, extensive buildings, but semi-derelict and really only open for a couple of hours on a Sunday morning. From that, Andrew Mawson, the priest, now Lord Mawson, really started to walk the streets, as he called it, loitering with intent, which we had to explain to the Minister for Health from Singapore last year is actually, of course, a criminal charge. So Andrew's version of asset-based community development was loitering with intent, walking the streets and encountering the people who lived in this very depressed neighbourhood. We're talking about mid-1980s East London, who had some energy, some spark, some ideas, some passion about what they might like to do, the activities, the gardening, the art making, the setting up of a small community cafe, and all sorts of things that started to thrive within these church buildings. And we started to develop a very locally owned, locally inspired community hub. And really for the first 10, 12 years, nothing that we were doing would have been recognised by the National Health Service or indeed by the local authority as anything really to do with health at all. But we certainly started to get an inkling that actually, whilst we were providing lots of activities and beginning our journey around welfare benefits advice and small employability programs and English language programs for the large Bangladeshi community that we had and others, we also started to realise that health was a critical issue for our community as well. And we set about building what we think may still be in Britain the only health centre built by the patients and rented back to the doctors. So we started to build out a community centre, new community centre buildings and a general practice building, a health centre, and then set about finding a group of GPs who kind of understood the social model of health, as everybody now calls it, or the biopsychosocial model of health, really long before those sorts of terms came about. And that was the beginning of our journey into social prescribing. The idea literally that GPs and nurses in consultation would get up out of their consulting rooms with their patients and walk them over to the community centre side of the building and introduce them to maybe a welfare benefits team or an English language tutor or an employability programme or whatever it was that they might need, or an activity group like gardening. Of course, that was the very, very beginnings of our journey, long before anybody was calling it social prescribing as well, actually. And then over the subsequent years, we formalised it. We stumbled, like many, across the idea of this role called, now commonly being called the social prescribing link worker. And then about 8 years ago, we rolled it out to our primary care network in Tower Hamlets. We're lucky in Tower Hamlets. We've had primary care networks for over 10 years now. And in doing that, we had to introduce social prescribing to a group of GP practices that really had no understanding of social prescribing or really the social model of health. And that was quite a journey of how to introduce the idea of the value of social prescribing, particularly in a very deprived community such as the one we're based in, and why social prescribing was not just good for patients, but good for the doctors and good for the nurses as well. And so we did a lot of work around how to introduce social prescribing, but it was really all about building trusted relationships. And in doing so, of course, it was critical that our GPs were really totally on board with social prescribing, and they were the best people at selling social prescribing to the GPs in the neighbouring health centres where we were introducing it to. And that really was the journey of social prescribing at Bromley by Bow. But it really came from, if you like, a community activism point of view of rebuilding communities that had gone through some really tough times over decades and decades in East London, and how you started to support communities, how you tapped into the assets within communities, the energy within communities, and how you created this bridge between the formal health system and communities, and how you built that through developing strong collaborative relationships between the voluntary sector and the health system and GP practices, but also with local residents as well. And that developed a whole series of resident-led projects as well. But I'm going to hand over to Najnin now, who can continue this story in the sort of most recent years of Bromley by Bow's development of social prescribing.
Thank you, Dan. So I'm Najnin, so I'm the Social Prescribing Training and Development Manager, but I'm going to be speaking today about from my experiences as Social Prescribing Manager, where I also made sure that I had my own caseload of patients. So I speak from a link worker experience. And as Dan mentioned, I think one of the opportunities we had at Bromley by Bow was that we were situated in a very seasoned, mature primary care network, and that really helped us into our advantage in developing social prescribing. So we developed primary care networks in Tower Hamlets, you know, I think it was 11, 12 years ago now. And so we had the chance to really, you know, work on what's worked for us, what doesn't work. And so just sharing that with you. So we commissioned our formal service that was CCG funded in 2014, and shortly after that we also had a cancer specific social prescribing service as well. And so we really understood that there needed to be a service pathway. We decided to invest in a service manager for a team of link workers, and that was at a primary care network level. Some things that we did to sort of engage and sort of really collaborate and sustain partnership working was to, you know, be involved in locality health and wellbeing boards, be actively and proactive in sort of working groups within the partnerships. We did a significant amount of training on social prescribing and the role of the link worker, and what referral needs to look out for with practices, with nurses, with reception staff, as well as GP trainees as well. So we're involved in BTS training, which is when GPs are training to become a GP, so we do a lot of work around that. When they're also training to become a GP, we encourage every practice to come and shadow us. Obviously in the COVID situation that's been a little bit tricky, but we found that what that does, it it helps build a picture of what social prescribing link workers do. And actually we see generally once GP trainees shadow us, there's definitely a correlation in terms of referrals. We also have, as an organisation, leadership at a board level. So we have a GP partner that's a partner on our leadership board for the charity, as well, vice versa. So our CEO is also a partner of our GP practice as well. And that in itself is a really strong indication of, like, you know, our commitment to partnership working and supporting our communities. We also have something in our borough that's really worked for us is Tower Hamlets Together, which is essentially a partnership collaboration of local health and social care organisations, and that's been a journey for the voluntary sector to really be active, and essentially we're a big organisation, so I think there's also a commitment to make sure that the smaller scale voluntary sector organisations also have their voices heard as well as have input. And then we've also, you know, in terms of the COVID situation recently, we're working together with Tower Hamlets Together on digital inclusion. How do we address digital poverty with all partners involved? And so that's some of the things that we've been doing to date. And I think, you know, partnership working, collaboration working, we all know it works. It's just very difficult to sustain. And I think, you know, just drawing on what Leanna and Dan have mentioned, it's a big system change within the NHS, and you know, there's some pockets of areas where primary care networks, you know, are fairly new. And I think it's definitely a journey, and it's an exciting journey, and we've definitely have had our ups and downs, and we know what's not worked for us. And I think just bear that in mind for any new primary care networks, you know, who are starting out on their social prescribing journey. Hang in there, and you know, it'll be lovely to hear from you all at some point later.
Great, thanks, Najnin. That leads me quite nicely on to our next speakers. What I want to say quickly, actually, I should have said up front, we are recording this session, and it will be for all participants. We'll send a follow-up with the link to the recording. It will also go up onto our website. And for those of you that are on the collaborative platform, we'll be uploading it to the London region. Also, please do put your questions and any comments into chat. After we've heard from a couple more speakers, we will have a Q&A, so it'd be really lovely to focus some of the things that we're telling you on the things that you would actually like to know. So please put any questions that you have in the chat. I'd like to introduce our next speaker, Khadija. I'm going to pronounce your surname incorrectly. Khadija Ardley. Is that right, Khadija?
No, it's Arije.
Arije. Can we see? Have you got your video on?
I'm trying to.
So Khadija is one of the link workers that has been joining our peer supports and has been extremely generous in giving me suggestions on things that we should be doing in London to support link workers. She's got a strong voice. She's has been a tour de force in her PCN, and really excited to hear her story of how she's made it all work. Khadija, I'll hand over to you.
Thank you. My internet is. Can you see me now? Because my internet is.
Yeah, we can see you.
Okay. Morning, everyone. Yes, like Leanna said, my name is Khadija. I'm a social prescribing link worker in Hounslow. Najnin played a very important role in our training when we started in November. So in Hounslow, we were the pioneers of social prescribing. We were recruited by volunteer organization. I was recruited by Groundwork London. So we had two volunteer organizations, Groundwork London and H for All, and there are 5 of us. I think what we did, or what was very good, was the training we had. We had a solid foundation with training. We were recruited November, December, it was training. So we started in January. And what I can say that was very good with the development was the open communication we had. So the PCN and also the clinical commissioning group, open conversation. Everyone was ready to be on board with us. And I must say, I've been very, very fortunate with my clinical director and my GP lead. It was a situation of, look, this is new, we're all learning, we're all in this together. It's for the same goal. We want a good integrated primary care for patients. So I think the development and creation was based on open communication, which is very, very key, and the support from the clinicians as well. And I can say the positive steps we took was I went to the practices to introduce myself, tried to tell them about what social prescribing was about. Lunch time, I'll be in the kitchen, just trying to say what social prescribing is about. We printed out leaflets. We were invited to MDT meetings. MDT meetings are multi-department teams. We were invited to PCN meetings as well. My clinical director would invite me to the PCN meetings to talk about social prescribing. We've been doing that, and it's been great. Because we had, of course, like, it's not everybody that will come on board at the same time. Some were reluctant to engage, but by going to the PCN meetings and talking about social prescribing, my clinical director will make it an open question for our colleagues. If you've got any questions, Khadija can give us updates on cases. I presented on some case studies as well. What else can I say? I would just say it's a two-way relationship, being open and communication, the support from the clinicians. You would have cases where you need to discuss with your GP lead. If you don't have that support, it can be very isolating. I have meetings with my clinical lead weekly. So we touch base, I discuss on what's bothering me, or what cases I'm finding difficult, or what's working, what's not working. It's for me, it's been very rewarding and fulfilling, because I have a group of GPs, I call them my champions, my GP champions, that are on board and ready to work with you, and having that open conversation. I cannot emphasize enough the open communication with everyone. We have the difficult ones, but we're trying to win them over. Like in Hounslow, my PCN, I have 10 practices, and we've managed to get 7 on board to engage. So it's a working process. I don't know if there's anything else I've got to say, but I would say it's open communication with the clinicians, with the volunteer organizations. Clinical commissioning group in Hounslow, the CCG consortium, have played a very big role as well. Yeah,
that's really interesting. I think you've covered all of the main actors, really. I think that's I think it's fab. I think some of the things that you've mentioned to me in our conversations, the case, you've pulled together some really practical engagement tools, and obviously it's been a bit of almost a year's journey now, but the case studies you were pulling together, and I think that you were talking a lot about the making the process pathway clear. It looked like you pulled together a really interesting, very clear illustration, which, if you're happy to share, I think it might be useful to share with everybody the process pathway that you guys pulled together at Groundwork. And I think the open communication, you were talking about managing expectations, and I think
sorry, apologies, I had a very short time to prepare. Thank you, Leah. So yes, definitely the pathway is very very important. For now, where the referrals come from the GPs, so they send us tasks, on system, we use system 1. We're trying to integrate system 1 with Elemental right now. So they will send us tasks on system 1. It would be from GPs. We're gradually moving to other allied professionals to send us referrals. I've been getting referrals from the community pharmacist and some from the district nurses. So for now, we're just, GPs will send you a task and we'll check if it's an appropriate referral or not. But it's usually on system 1. So if you're using EMIS, I think it's going to be the same way. Managing expectation, I cannot thank my clinical director enough, because we've had at the PCN meeting to say, when you send Khadija referral, she might not be able to pick it up in a day or two. It's just her. So we have like a 14-day waiting period for them. So when I'm being sent a referral, they are aware that I would get in touch with the patient within 14 days. And it doesn't mean that they've sent me a referral on Monday. I have to call that patient on Monday because there's a list and there are other practices to consider. So managing that expectation to let them know, setting it out clear that there is a waiting time. I think the ideal time, if I can remember from what Najnin was telling us at one of the trainings, will be like 3 weeks, depending on how your caseload is. But it's always good to manage expectations. Thank you, Liana.
That's great. Thank you, Khadija. I think you guys have pulled together a lot of work to make the communications across your 10 practices, which is a huge number of practices to be managing in a PCN. You've done a lot of practical work to make that comms engagement easy for you. But I think it feels like what you're saying is what underpins it all is really leadership. So I think it'd be useful to hear from Sudan Roy, who is the clinical director that you are so affectionately referring to. Sue, are you on the line?
I am. Can you hear me?
I can, yeah, that's great.
So I've only just joined, I really apologise. So I missed a bit of what Khadija was saying. So I love the fact that she was saying lots of positive things about me.
Yeah, she was. I mean, I think she's drawing the examples that really making the social prescribing work across the PCN has been down to your ability to open doors, make space in MDT meetings, and really encourage some of the other health professionals to understand perhaps social prescribing and as a result sort of get on board and make some appropriate referrals. But it'd be great to hear from you around what's needed from health professionals to accelerate the uptake of social prescribing in the sort of the primary care sector.
So I'll just summarise a little bit about us. I think you might have mentioned it. There's 10 practices. We've got a population of 80,000, which is can be quite challenging. I think for most GPs, we really didn't understand what this role was. So what has been really amazing for us is Khadija. So she's been very open to lots of possibilities of referrals. If we had very strict guidance, I don't think we would know who to refer. I think what's worked for us is that we really started, and I think actually other networks in Hounslow, they've started with one practice, really getting a sense of how it works. So that started with my practice, not really with me. Khadija's lead was one of my colleagues, and they set up the structure so it worked for the practice in a really practical day-to-day general practice way. So for us, we don't have to do a separate referral form, which would just take time. We can just task Khadija whatever issues we've encountered with the patient, so she knows why we're referring the patient, and then she will pick up the task accordingly. And we advise the patient that she'll contact them as soon as she can. So we're not saying it's an urgent contact. And so it worked well for us, to be honest. Once you have one experience where you start to get some positive feedback, that makes you refer more. So it worked very well with us when it started. And so we are probably the highest referrers in the area. And the way we've tried to sort of educate other practices in the network is really by the meetings we have. So now we're going to have Khadija attend every other meeting. At the beginning, she was attending a little bit more to explain her role, what she could do. At one of our last meetings, she gave a presentation of some of the cases she was encountering. So again, it just gave GPs examples of the type of situations she could help with. And I think that's really how we are going to sort of educate practices about the value of the role. But it's been really valuable for my practice, and I'm in a health centre with 3 other practices, so the 3 of us find it really valuable. Is that helpful? I'm not sure.
That is. I mean, do you have any sort of closing tips for how social prescribing link workers might engage with clinicians that are perhaps a little bit skeptical of social prescribing, or don't have the time, and then maybe they're too busy to sort of get their head around social prescribing?
So networks do have to have regular meetings. So I would probably ask for a slot on one of those regular meetings to be able to just present what they could do. The other thing that I think Khadija did was actually get in touch with all the practice managers in all the practices. So the link workers could start with the practice manager and then maybe liaise with some of the doctors, have a presentation, that sort of thing. Or the real target is patients that come in a lot. So initially we did searches on patients who were frequent attenders. So that's a real sort of, if you see a frequent attender who then you refer to the link worker who then actually makes a difference, you see a real positive result, that will encourage people to understand what the sort of role is as well, I think. I think there was a lot more we could have done, but obviously everything changed because of COVID. So maybe we would have had more case discussions, sort of more actual experiential information to share if we were all actually meeting, but all our meetings are virtual, as is this. And actually, I think the doctors have all been a bit distracted by other things at the moment. There's a lot going on.
Yeah, it's interesting because I think in actually taking the sort of pan-London landscape, there's actually quite a lot of social prescribing services that I think have, whilst link workers have been pulled into work that isn't necessarily social prescribing in the moment, doctors have actually had their eyes opened to the value of social prescribers, and I think that's now some space has been made for link workers to really support some of their most vulnerable patients, and I think that will morph now into a really much more established social prescribing programs going forward. Thank you, Sue, that was really helpful. If you are able to hang around just to see if there's any questions that are coming through for the next 15 minutes, in about 5 minutes time for the last 15 minutes, that'd be great, but don't worry if you can't.
Yeah, that's fine.
Dan, this leads us quite nicely on to where we are now, and what the current situation is for social prescribers, and for social prescribing more broadly, actually. Would you like to, are you on mute?
Great, thank you, Leanna. That's really helpful. Yes, exactly the point that we were coming on to, really. So, but just to sort of, the journey is still so fresh, isn't it? Primary care networks are really, across the country, really only 18 months old, if that. This commitment from NHS England to employ the first 1,000 link workers. So most of those link workers are really only in post about 12 months now. And then this stimulus for an extra recruitment round of another, well, we think it may be another 300 or 400 link workers that NHS England have just supported in the last month, really. So really, really rapid growth in a very new environment, i.e. the primary care network environment, and introducing something into general practice that is a social intervention into, what has to be said is a very clinical space. So it's not surprising that, as we heard just now, it hasn't quite landed fully yet in all the practices. But as both everybody's just said, really, under COVID, social prescribing and social prescribing link workers really became a key part of the response to COVID in terms of supporting, I think initially certainly contact with people who are shielding and the most vulnerable, and then many practices started to widen that out and started to really sort of interrogate some of the data within general practice and start to think about who else might benefit from being given a call. Particularly, I guess, because of the COVID situation of people being at home and isolated. Certainly at Bromley by Bow, we started to look at our lists of patients with anxiety and depression, low mood, and thinking about calling them, and we did, in the hundreds. But then you start to think about patients with long-term health conditions as well, patients who live alone, for example, whatever it is. And this started really, I think, to reveal a new way of working for social prescribing, which is, in addition to responding to referrals coming from clinicians who've just seen a patient who's mentioned a social issue, but actually starting to use the data that sits within primary care to identify hundreds and potentially thousands of patients within general practice lists who might benefit from social prescribing type calls, and then potentially longer term support from a social prescribing link worker and referral onto other services. And I think this is, in a sense, almost like a new opening for social prescribing. And of course, that starts to make one think about the volumes that might be, and therefore the ongoing expansion of the number of social prescribing link workers within every primary care network. And I think that's probably the next phase. And it always was, to be fair, the NHS England's intention that every primary care network would probably have 4 or so link workers. It's also got us all into thinking about the potential areas of specialisms of social prescribing. I think the idea being that every link worker would be a generalist, but some of them might also specialise. You start to think about groups like young people, for example, who probably need a slightly different type of link worker, and they will undoubtedly need different types of activities to be referred on to adults, for example. And maybe they need to look a bit more like youth workers, for example. And of course, this comes alongside the expansion of health and wellbeing coaches into primary care and care coordinators as well. So really what we start to see is the formation of a not insignificant non-clinical team that sits within primary care, that sits within primary care networks, allied to the work of clinicians, but also with a strong link to the voluntary sector.
Dan, can I just interrupt? Can you tell us a little bit about your job as the regional facilitator in London? Yeah.
Yes, certainly. So part of my role is around, along with Leanna, Susie, Kerry, who's on the call now as well, is to support the development of the system in terms of social prescribing across London. For those who don't know it, London is divided into 5 STP areas, and we work at that level, and these are quite large groupings of boroughs. In North Central, it's 5 boroughs. In North East London, it's 7 boroughs, for example. So these are quite large systems, and the idea is to start to develop these as health systems, as mini health systems. Within that, we support the individual boroughs, and we support at times primary care networks, individual primary care networks as well. And this is all about supporting the system in terms of understanding social prescribing. It's a lot about elevating the importance of the role of social prescribing link workers. It's also about forging links with the voluntary sector and local authorities as well, which are often somewhat overlooked in this whole picture. And it's about, that's the title of today's webinar, is about making social prescribing everybody's business. So we're there to support the development of social prescribing, the embedding of social prescribing, and helping everybody to think about what the future journey of social prescribing is as we move forwards. And it's very much, in a sense, some of the work around that was mentioned earlier around how do you introduce social prescribing, it's doing that on a systems level. I think the next conversation, or one of the next conversations also, is around the funding of the services to which social prescribing link workers are referring clients onto. We know that those services are under significant strain provided by the voluntary sector, but not only. Link workers are also trying to refer clients into services within the local authority, DWP services and others as well. And those services are also under considerable strain. So it's also, and this isn't about really creating new demand, it's about identifying existing and unmet demand. And in order to do that, we also therefore need to have a dialogue around what the funding is and what the provision of services are within our communities. But also we need to think about how we unlock the resources that reside actually within residents and within neighbourhoods as well. It's not just about funding, it's also about supporting local people to do more for themselves as well, and giving them the support to do that as well. And I think that is probably the next step. And of course, we're sitting in a very adverse situation at the moment with COVID, and we've just come through 10 years of austerity as well. So, that's a challenge, but I think social prescribing is absolutely the thing that will help to release the potential that we have within our communities, and to really create this dialogue about what the resourcing needs to be for the services that will support social prescribing as well. So that's the role that we have in London, and Leanna's role specifically is around specifically supporting social prescribing link workers in London, and really I think helping them. It's a new profession. It's a profession that's finding its feet. It's a profession that also has an important contribution to the shaping of health services. I heard a lovely phrase by Dr. Jagan John the other day, which is actually, maybe we need to get social prescribing link workers training GPs, which I thought was a really interesting thing when one thinks about sort of how one thinks about the hierarchies, if you like, within health centres. But it is also thinking about, if we want to move to a more holistic approach to health and well-being, there could be no better professional to share their experience than social prescribing link workers, because this sits absolutely centrally to the work that they do. So I think that's a really interesting way of thinking about things. And I think social prescribing has always been described by Dr. Michael Dixon, who's the head of the National Social Prescribing Network, as essentially a Trojan horse to help the NHS and the health system to move towards a sort of biopsychosocial model of health. So we also need to think about social prescribing as culture change as well.
Thanks, Dan. A couple of things that I wanted to pick up. I mean, we've talked a little bit about my role as supporting link workers across London. There's somebody at my door. But I think for me, there's a big part of this. In terms of bringing link workers into the system, link workers have joined and are joining already existing teams. And I think it's really important. There are so many ways in which link workers could and should be influencing the kinds of people that social prescribing is supporting, the ways in which the service is delivered. Some of you were mentioning in the chat box some of the concerns around supervision, and I think that link workers should be brought into the conversation around what kind of support do they need, what time do they need earmarked in their week to ensure that they are able to engage with local services and understand about the kinds of prescriptions that they could be making, what services are available and out there that are really going to be really crucial for the referrals they're going to be making with the people that are being passed to them by the GPs to contact. I think a couple of things that I would just shout out in London. As part of my role, we're going to be launching a champions network for link workers, and that's going to be bringing link workers into the conversation with commissioners, with the local the strategic transformation partnerships, which are the 5 areas in London that are looking at collective commissioning for lots of the other smaller CCG areas. And for any link workers out there that are interested in being part of that, please do drop me a line. We're going to be, I know that across some of my counterparts across the UK, we're going to be surveying link workers on a regular basis. We are funded by NHS England. We don't sit with them though. so we can gather information and intel from you as link workers as to what the key frontline concerns are, so that we can feed that back and put pressure on the system to make sure that some of this stuff is being addressed, is that they are aware of some of the challenges you're facing, and it can be addressed at perhaps a more national level. Linda's saying that it can be a lonely job. I think it's really crucial that you guys are looking for your local regional learning coordinators and are saying that you want to be linked up with other link workers in your local area. These are all things, you know, we haven't actually talked about how important it is that link workers connect with each other. And for those that are employed directly by PCNs, don't necessarily have a voluntary sector to a wider team in the voluntary sector that is employing them, or a GP federation perhaps in some cases. It really is important that you are reaching out and trying to find other link workers and understanding, sharing best practice, as well as being a shoulder to each other, because it is a tough job, especially at the moment when you're having to deal with some really, really difficult cases over the phone. Anyway, enough from us. There's some really interesting questions coming through on the chat. I'm going to just answer one really quickly. Someone asked about mental health specific social prescribers. This is something that is in London. We've got 2 that that are on a trial in central Westminster. They are funded by the Mental Health Trust there, and actually interestingly the Mental Health Trust are supporting and putting extra cash in to make sure that there is a service manager in charge of the whole service, so that those mental health link workers can sit within the PCN, the primary care network link worker service as well, and all of that sits under the umbrella of, or the management of, the local services, Council for Voluntary Services in central Westminster. It's a really interesting model. Bromley by Bow soon will have a mental health specific link worker funded by ELFT, our local mental health trust. So there is definitely an interest in exploring this. We had a question about engagement with the CCG, and I was wondering, Sue, do you have much engagement with the CCG, and how important has the CCG been in helping develop your social prescribing service? Is that something that you can comment on? You're on mute, sorry. Have we lost you? I can't hear you. Oh, I have to unmute you, sorry. There you go.
Can you hear me now?
Yeah, sorry.
So in Hounslow, I think we're quite different, because we have a consortium which other networks maybe are involved in federations. So our consortium sort of manage and coordinate most of the link workers. So in terms of the social isolation, all the link workers will be linked together for the 5 networks in Hounslow via the consortium. And the consortium do any liaising with the CCG. So to be honest, directly, no, I don't have anything to do with the CCG. I don't think I've had any conversations about link workers with the CCGs, but the consortium may have done.
That's interesting. Dan, what have you got any thoughts on engagement with the CCG, and how what the sort of the important elements of developing a social prescribing service, you know, where CCGs can be useful?
Yeah, absolutely. I think it's about thinking about the aspirations for the area rather than just the individual primary care networks. I think health inequalities is always a good way to start, to think about how you start to support the more deprived areas within a particular geography, for example. Is definitely one way to look at this. I think it's about trying to have a joined up conversation as well. So something like the health and wellbeing boards, for example, where you've got local authority representation, you've got housing associations, you've got the voluntary sector, and you've got the clinical sector, who kind of therefore bring a rounded conversation to the needs of that community. Because you know, the needs that patients have, of course, that manifest themselves in general practice are often needs that are to do with housing, for example, or welfare advice, or a myriad of other things that touch on the other services that are provided and the other concerns, if you like, the concerns of the local authority, for example. So I think that's definitely one way to do this, and to get social prescribing to be seen as, you know, not just a challenge, if you like, of implementation and systems change for the clinical system, but also for everybody else as well. I definitely think that finding strong advocates from within the clinical constituency is really important. Finding GPs, respected GPs in the geography that you're working in, who are advocates for social prescribing and who are willing to speak publicly at events and CCG meetings and so on, is also very, very important as well. Yeah.
I think one of the things I'd like to add to that is I feel that there is quite often we sit in meetings as part of our jobs as NHS England associates, where we're discussing the challenges that link workers face, and there are no link workers in the room. And I think that it's definitely co-production is something that the commissioning structures are interested in engaging with but aren't sure how to. So I think it is our job in some ways to make it easy for them. And I can't stress enough the importance for anybody that is a link worker themselves or is managing link workers or looking at a social prescribing service to make sure that link workers have enough time to, or social prescribers have enough time to engage with all of the different actors within the system. Because I mean, Kate Hazelwood has put a few comments in the chat, and I think one of the questions around how do we actually make sure that this is a whole system approach, that has been the challenge forever. And I think that one of the really the can you say an upside to COVID, one of the benefits, or one of the things that COVID has afforded us in some cases, is the opportunity to all come together. And that isn't necessarily, that's working in some areas better than others, and it's not on the link workers or social prescribing to facilitate that, but it certainly is. Link workers have an opportunity to, if they are truly to be the bridge between primary care and the health sector and the voluntary sector, they need time to be able to build those relationships. And one of the things we haven't talked about is the opportunity for link workers to spot, identify unmet need. They are speaking to people who have needs for services, and if they are going out and looking for those services locally and they don't exist, they should be involved in the designing of those new services to meet this unmet need. They could be extremely useful in commissioning relevant and meaningful services locally. And I think it's really important that that social prescribers are being consulted when it comes to commissioning locally, either via the local authority or via the clinical commissioning groups. And that's one of the things that we are trying to facilitate in London, certainly. And the GLA we haven't mentioned, but one of the boards that Dan and I both sit on includes the Greater London Authority and I'm trying to say, there's lots of acronyms, so I'm trying to say them all out, and London Plus, who are an umbrella body for the capacity build the voluntary sector organisations that deliver the prescriptions that social prescribers are referring to. We're part of a consortium, and we meet regularly to talk about strategy for social prescribing across London, but also delivery. How are we practically going to do this? Because I think sometimes a lot of this stuff can get lost in, you know, we can talk about ideas for a long time, but some of this needs doing. And I think that I think it's actually really encouraging that NHS England are investing in posts such as ours, because it creates some space to actually action some of these ideas and do something with this wonderful network that we're generating. Najnin, just to put to you, obviously you were, just to speak a little bit more about this whole system approach, you definitely engaged a lot of people across the board, local authorities, local voluntary sector organisations, advice centres. Can you talk a little bit to that point of how do we genuinely engage the whole system?
Yeah, and I think you know, it does take time, and I think we took really proactive measures to try and engage, you know, we started our journey a few years ago, and just engaging with some of the GP practice was actually quite hard work. It was about going physically into the GP practices. There's something about visibility, just being seen. Even when we're having clinics, for example, we make sure that we have our door opened so that every member of staff sees us, sees us. So that's helped. And in terms of local authority, we've worked quite closely through working groups, and that's been really helpful. They've understood our role. There's a significant amount of work that we had to do in terms of educate people on what the role of the link worker is, what is the remit of the role, what we can't do, what we can do. So for example, with the local authority, we work with their poverty team to understand, see if there's anything that we can do in terms of supporting welfare issues within our sort of locality. We've done a lot of engagement with different types of primary care healthcare professionals, so not just the GPs, but the patient assistants, the reception staff. They are such a valuable asset within primary care. They know immediately as soon as that person rings what they really want. They know everything about the frequent attenders, and really utilizing their skills, their knowledge. So we've done lots of training with them. There's the therapies teams within the community that unfortunately at the moment we don't have a referral system for non-primary care healthcare professionals, but it's so important to understand what the role of social prescribing is and what it can do, and it's a significant amount of engagement work, and that's taken a good few years for us. It's not been an easy process, but it's we're at a point where we're successful because of that sort of constant engagement process. Go out there. I know it's very hard at the moment, but if you can set up sort of network meetings virtually, identify, speak to as many people as you can to see who the key influencers are, who are the people that make your decisions about the service pathway, or who can make, a case to either get more funding for you or can encourage more referrals from other referrers, for example. There's it's not just mapping out services, it's mapping out who the key players are. And so it's a process, but I hope that's answered.
Yeah, that's great. Thank you. I'm going to finish on one really practical question, and actually, I think this could be one for Sue. How someone's asked, how do they get invited to meetings during COVID? And I think a lot of the things we're talking about, keeping an open door, making sure you're around in the kitchen, being available to GPs to really sort of demystify social prescribing and keep some visibility that you're there. What do you do when a lot of link workers have started during COVID, and what do they do in order to push themselves, elbow their way in at a time when everything's being done virtually? So can you try and unmute yourself? I'm trying to unmute you, but I can't. There we go.
I'm often in my room all day, so I'll be here for 12 hours. So I won't see people in the coffee area and those sort of things. We really just do it by communication with tasks on System 1. And we all also have Khadija's phone number if we need to follow up with anybody. Is that what you were asking?
I think it's more around advice to people about what they do if they don't have those relationships with their GPs, or they're quite new to post and they don't know I'm guessing obviously they need to find out who their practice managers are and start to, I guess my answer would be that they would be persistent, that they would, but what's your thoughts from the being in the shoes of that individual?
Here, all the there's 5 clinical directors in Hounslow, and we all take it as it's one of our roles, it's one of our remit. So I think if the link workers don't feel as if they're getting any practice to engage, I'd feed back to the clinical director. I would then contact my practices and say, what's going on, why aren't you using them, and find out what the issues are for them. But quite early on with Khadija, she met all the practice managers. That was all pre-lockdown, so she actually met everybody. So yeah, I'd keep feeding back to the clinical director. I think they're the ones that will action something.
Yeah, I agree.
Otherwise, it can be a bit demoralizing if you're just constantly trying to be seen, I think.
I think one of the other things is link workers. The arrival of link workers has presented an opportunity to maybe offload some of the things that that practices might not know how to get done otherwise. And I know some link workers that have used that as an opportunity to develop a relationship. And I wouldn't want link workers to fall back on making themselves useful in whatever way in order that they develop those relationships, but perhaps being really forward and asking. I think your point earlier to tackling some of those frequent attenders, you know, what problems in the surgery can you solve by implementing social prescribing in a really proactive way? And I think using social prescribing as a solution to some of the challenges that the surgeries are facing could be a really nice way in for some of the link workers that are maybe struggling to engage or elbow their way into meetings. And what I would say,
so absolutely pre-COVID. During COVID, one of the things, I don't know if Khadija found it that helpful, but what's useful for us is that we gave her a list of the people that live on their own, you know, so actually we gave her a list of all the vulnerable people, but it turned out lots of them had family. But if you could have one for a list of people that just live on their own, just having someone contact them is really useful, you know, because otherwise I may not have spoken to anyone in the last 6 months. There's lots of roles at the moment out there still for them to offer.
Actually, one of the things, this is a really nice point to end on, actually. I think we have the people we haven't mentioned that are major actors within this whole program are the people that are receiving the social prescribing. And bearing that in mind and thinking about how social prescribing can have such a positive impact on people's lives and who is it likely to benefit the most, and start with impact in mind and work back from that, I think is really, really important. And that is probably a whole other conversation to discuss about how we measure the impact and talk about how do we evaluate evaluate social prescribing and really tell the story in a meaningful, data-driven way about the wonderful things that it's doing for people's lives. That's a whole other conversation to have. Okay, what we're gonna do now is just go into breakout rooms. I think we're gonna do 10 minutes, just a bit of reflection for those of you that want to stick around and discuss what we have discussed today, because it might be quite nice just to talk amongst yourselves about some of the stuff we've heard, and perhaps, I'm sure there's still some questions we haven't answered, and I'm sure maybe they can be answered in your breakout groups. So we're going to put everybody into breakout rooms, I think of between 5 to 8 people. So for those of you, thank you so much for all the people that have contributed to the presentations today, and we'll join back in 10 minutes to hear a little bit about what some of your reflections have been for those of you that want to stick around. So you'll be allocated a room, and see you in 10 minutes.
Thank you.
Dan, are you still there?
You went into a group, I think.
Okay. Oh, that's actually quite good. Actually, he'll love that.
Yeah.
All right. How's it going? Are there still quite a lot of people to go into rooms?
Yeah, I'm just moving people around just to make sure that everybody has someone in their room. But
okay.
It seems like, yeah.
We've still got some people in the main room.
Oh, oopsie.
Is there a reason that we've got people in the main room?
Maybe people haven't joined their room. If anyone is having trouble joining their room, please do let us know. Maybe unmute yourselves, and if you don't want to join, that's all right as well. But yeah.
Thought that went okay.
Yeah, thank you very much. You're doing great. You're a star.
This is it's fun actually. It's actually fun.
Yeah.
You know, like it feels relevant. It feels really close to all of the things I'm thinking. So it makes sense. I think it's good. And I think it's nice. It'll mean that we can you know, I can share this with link workers, and I can run a similar session with my link workers if I decide that I want to do something a bit more London focused. I mean, I know that this has been quite London focused, but we could do something more practical.
Definitely.
I think, yeah, it's interesting that there's still a lot about engagement, and actually maybe that's something.
Yeah, I mean, I know that NHS England are going to be doing a session on how do link workers engage with their PCNs. I mean, it's going to be so crucial because, I mean, there's like 400 link workers going to be starting in the next 3 months across the UK, maybe even 500. I mean, I don't know whether it's, and they're going to be there'll be new link workers walking into PCNs that have got, where a lot of people are working remotely. I mean, maybe quite a lot of the link workers are going back in now. It's interesting. Kate, you're in our room. Kate, are you on? Maybe I need to unmute her.
They should be able to unmute themselves now.
There's actually loads of people in our room.
Yeah, 4 people are here. But no one has messaged us to say that they're struggling.
Could you, 1, 2, maybe they don't feel like it.
Yeah, they might not be at their computer right now.
Oh, that's a good point. Yeah.
I have message to say as well. Do let us know if you have any video trouble or
So we'll do it really quick. How many people have stayed?
I think it was 56.
Yeah, we've done 10 groups. Yeah, I would say about maybe 40, 50. Yeah.
So we'll just do a really quick whip round. I should have said actually. Can we broadcast to the breakout rooms?
Yeah.
Could you just do a broadcast message saying, please pick somebody from your group to who'd be up for giving a couple of points if we call on you?
Yeah.
I'm actually going to go and get a quick drink. Should we bring everybody in at 10 to? Give them another 5 minutes?
Yep.
Okay. How many people have we got?
We've got 20 so far, well, 18 so far. And people are trickling in.
Okay. Volunteers. This is the volunteer bit. Who would like to give us a couple of things that give us something that came up in their group? Who would like to start?
Oh,
Can't see.
hello.
Hi, Tina.
Hi. Yes, I'd be quite happy to start. We were talking about abuse in our group. We couldn't see everybody, but right at the end, and then a lady came and said that she was, she had suffered it as too, and that led her to do her social prescribing link work, and that she'd done some work recently with Mind. But I'm a very small organisation up in Norfolk. We do creative projects, and we did it originally for domestic abuse victims, and people opened up about sexual assault within domestic abuse. Even if they'd been through charities, they hadn't necessarily talked about that. They also opened up about having suffered CSA as well as children. There's a close correlation between that, and it affects people's mental and physical health. And I'm very interested in how link workers can touch on what is a really difficult to talk about subject, and how doctors' surgeries, PCNs can actually be aware of this, because it's a massive, massive problem across the country. Particularly in Norfolk, we have 9,500 children that have reported CSA, and the majority of CSA goes on behind closed doors. About 80% is behind, interfamilial, and that often doesn't get reported. So yeah, it's a little bit off topic in some ways, but I'm just so keen to get
What
understood out there.
To broaden it out slightly, I think what you're talking about is making sure that link workers are. There's a big question around what training do link workers need in order that they're able to have conversations and feel comfortable to create a safe space and to feel comfortable themselves for somebody to disclose. And I know that children, there is also something around social prescribing. Everyone could benefit from social prescribing, but thinking about the group that social prescribing might go to next, I think children and young people is a really is top of the list. And I know that it's being piloted in a couple of areas in London right now.
That's good. Yeah.
So it's I think there's a couple of things in there. I think there's also something around making sure link workers are really well supported and have not just a referral relationship with the charities in their local area, but also a reciprocal ongoing relationship. So if they have a concern, they've had a call with somebody, they had a concern, and this applies to somebody that is is disclosing suicidal thoughts, or somebody that is struggling with a work issue or a mental health issue, that they could pick up the phone to any of those organisations. I know that this happens in some of the areas with local mind associations, link workers have a close relationship with some of the people that they refer to. They may pick up the phone and say, I've had this situation, I'm not sure what to do about it, this is how I handled it, what do you think? So it's very, very, it's like very informal, almost like a supervision or a clinical risk type conversation, to share expertise, because obviously those local charities, link workers, are never going to become experts in sort of child sexual abuse or mental health issues, but what they can do is draw on the expertise of the community, the local local small local organisations like your own. Thank you so much for that. Anybody else that would like to
can I just say that I actually I do volunteer with Tina, and so have the same struggles, but I wouldn't even know where to find a link worker in Norfolk. We say the word social prescribing in Norfolk, but it doesn't seem to really go other than.
They should be finding you. Most areas should have a link worker now, and by the end of the year, almost every PCN should have a link worker. So I think it might be a case of calling your local doctor's surgery or reaching out to your local clinical commissioning group and asking who is heading up the social prescribing service, and trying to find getting a connection that way. But asking a local doctor's surgery if they offer social prescribing, and if so, who is the person, could be a way to do that.
They have only just started doing that. One of the ladies I support has been offered some inappropriate link work. She was offered knit and natter, which is not her thing at all. But I do know who is overseeing it. Is our local Community Action Norfolk are overseeing it. So
that's interesting. Well,
I've written down to have that conversation direct with them.
Good, because it's really important that you're on their radar.
Yeah.
Thank you guys. That was helpful. Who else would like to share?
Hannah have mentioned they were happy to also feedback.
Great.
Hiya, can folks hear me?
Yeah, just about.
Yeah, great. Yes, we were talking about a bunch of different things and kind of circling around so I work kind of on the boundaries between social prescribing work, and then also work with a lot of health practitioners and activists and artists, and basically we're all doing the same work. And what we really need is to be setting up networks where we can sort of kind of start working together and supporting one another and understanding the links between the work that we're doing and sort of co-supporting. So we were sort of talking about the idea of putting it to attendees of this meeting potentially, to see if people would be interested in having that kind of in being invited into that sort of a network to start sharing thoughts and ideas and learnings, and kind of strengthening all of these different networks by coming together.
I think that sounds like such a fantastic idea, and I think the more that we can be creating spaces, inclusive spaces for both sides of all sides of the engagement, actually, so all of the local players, the less likely there is to be duplication, the more, you know, we're going to work more efficiently on a really kind of like practical level, but on an emotional human level. I think there's one of the things that's really happened in the last 6 months is people are connected, you know, that there has been a reason to connect with more locally, and I think there's a great deal of appetite out there for it right now. And I think that actually you'll probably find that money that will be available for any of the ideas that you come up with as a group, you will have a much better chance of getting access to it if you are working collaboratively. So there are sort of like human drivers for that, but I think also the sort of the pragmatic practical drivers definitely always follow that. Anybody else? Thank you, Hannah. Anybody else? Last points.
Hi. Can I speak? I was in a group with 2 people from across the country. My name's Jane Hughes and I'm from Manchester. And how we did it in our group was from the discussions we've had before, we just thought of one takeaway point, you know, that we'd kind of taken away. So the first guy who was in our group, Mark, was, forgive me Mark if I'm getting this wrong, was an urban planner, an architect, and he loved the idea of Bromley and Bow building the centre, and his other point was just a bit of a concern that we might be reinventing the wheel, you know, that some of these things have already been happening. And that was a little bit echoed by Sam, the second person, who was actually a mental health link worker in our group, who sort of said that she felt the occupational therapist professional group hadn't been as involved as she would have liked in social prescribing. So that was her point. And then my point was, my interest is training of social prescribers. And my takeaway was, it's a shame that social prescribers are having to kind of fight for the role and meet in tea rooms and, you know, things like that, you know, to get the message out there. I mean, I know it needs to be done, but really interesting some of the discussions we've had about how to, you know, make sure that the role is known and we communicate about the role.
And I think, yeah, to pick up on your last point, I think all of the actors within the system have a responsibility. NHS England have a responsibility to make sure that this is implemented in the correct way. But they also, I think, have taken quite a forward-thinking approach in the sense that they are not overly authoritative in the way that this should be implemented. One of the great things and the beauties of social prescribing is that it can be localised, and we can respond, as we heard from the GP and the link worker earlier, it could and should be responsive to the local need. And in that situation, it then is incumbent on us as link workers and service managers and, you know, CCG commissioners of the service to make sure that this message is getting out there. I think it is Dan could speak, do a whole webinar on this. You know, how what we are going through right now is a huge cultural shift within within primary care and the way it's delivered, and that is, you know, I actually think, even though it's a lot of work right now, I think we're doing a great job, and I think there's obviously a lot more work to do. And so whilst I hear that, you know, it's exhausting and it's hard, and it's our job to make sure that link workers are supported in that process and aren't being taken advantage of or are being utilised correctly.
Can I just say one more thing, Leanna? I think Dan should do that. You should do more. It would be great. You know, I think this has started a process off, and it's been wonderful to listen and get your views, and thank you and thank Dan. So please do more. Yes, please, another one with Dan speaking all what you've just said.
Yeah, just to come in there. Thank you, Jane. That's really helpful. And let's do another one then. And I guess we're in this situation in a sense where bottom up meets top down. You know, social prescribing over the last 15 years has been something that's been percolating, been developed not just at Bromley by Bow, but a number of other places across the country, usually by actually these collaborations between the voluntary sector and some GPs who really understood the social issues that their patients were facing and so on, and why collaboration made sense. Of course, it's now been adopted as national policy, and so it's bottom up meeting top down. And I think you know, this is a really interesting juncture. You know, the NHS have funded the salaries, which is absolutely brilliant, and the NHS are giving support. Leanna's role, my role, and others similar to that across the country. But it is also about empowering local systems as well. It's about forging those relationships between the voluntary sector and clinicians in GP practices, who heaven knows, you know, I know from our GPs at Bromley by Bow, you know, they arrive at 8 o'clock in the morning, and they're lucky if they're getting to go home at 8 o'clock in the evening, and hardly have time to get to know anybody outside of their own practice. And you know, it's about how do we open that out? And yeah, let's do another seminar on that. That would be really fascinating to do.
Definitely.
Fab. And on that note, thanks, Jane. On that note, Berenice, do we need to say anything about another? I'm not sure what the wrap up is. Sorry.
So the polls are not working for some reason, so we're not.
I can't hear you. Sorry, Dol.
So I'll send a.
Berenice, I can't hear you. Thanks everybody for today. There will be an email out after the session with a recording, but also the schedule for upcoming webinars that Bromley Balboa are delivering. Hope to see you at one in the future also. Please feel free to drop us a line if you have ideas for things that you would like us to be delivering. Be great to be putting on more things that you guys would like to be hearing about. So let us know.